Okay, so we are going to start chapter 12 now. This is going to be on the skeletal system. So when you take a look at the skeletal system, the overview, some of these first slides are going to go pretty quickly because a lot of it is recapitulation from chapter 4, which we already covered. So the skeletal system basically has a supportive type of function, and it is in the connective tissue grouping. So we learned about that in chapter 4. And so it basically is part of the supportive connective tissue component along with cartilage. And so this is basically where we're going to find a lot of our cartilage, which is typically at the joints where the two bones come together. And then, of course, the ligaments, which is also fibrous connective tissue, which is essentially joining one bone to another. And then, of course, tendons are connecting the muscles to the bones. So let's go ahead and take a look at some of the functions of the skeletal system, some of which we're kind of already familiar with. The first one that we're going to see is a support role. So the basic skeleton is going to be supportive. And so it allows for support and structure. It also essentially works with the muscle system for the movement of the body. So ambulation, so the ability to move around. It's also going to be important for protection. For instance, your skull bones are going to be protecting your brain. Your ribs are going to be protecting your heart and lungs and so forth. Another thing, so these are the kind of the structural things, the things we think about when we take a look at the skeletal system, but then also we take a look at the skeletal system. It's also responsible for producing the blood cells in the bone marrow. And so that's one thing we see. And then, of course, it stores minerals, in particular calcium and phosphate. It also has a little bit of fat in there as well, although that's not where the bulk of our body fat is stored. The bulk of our body fat is actually stored just beneath our skin. And so this is a big, huge reservoir for calcium and also for phosphate. So let's take a look at the anatomy of a bone, in particular of a long bone. So the first piece that we have of a bone is called the diaphysis. The diaphysis is the long shaft of the bone. So basically, if I kind of do my little Scooby-Doo bone here, this is the diaphysis. So this region here is the diaphysis. Within the diaphysis, you're going to have a cavity called the medullary cavity. So there's an open area that's surrounded by ribs of compact bone. We talked about that in chapter 4. So essentially, you have these ridges of compact bone within which then you're going to have your medullary cavity, which is that center component. The medullary cavity on the inside is lined with a liner called the endosteum, which is the inner liner of the medullary cavity. And oftentimes it will be filled with yellow bone marrow, which essentially is where you're storing fat. And that's where the fat comes from in bone itself. The other piece here is the epiphysis. So the epiphysis is at each tip of the bone. So it's on each end of the bone. And within the epiphysis, you have spongy bone, not compact bone. And here is where you see your red bone marrow, which is where your blood cells are going to be made. So a lot of your blood cells are going to be made here. So here's kind of like the official view of it. You can see you have your diaphysis, which is a large shaft. Your epiphysis, which is the actual tips of the bone, full of spongy bone. Notice the medullary cavity is open, but it's got a lot of vasculature. So it's highly vascular. Got a lot of blood vessels going into your bone itself. And then on the inside, just the inside edge of it is going to be a single layer of endosteum. So it's kind of like a liner on the inside of the medullary cavity. On the outside of the bone, you're going to see an outer layer, an outer liner. And that's called the periosteum. So basically wraps the bones in sort of a tough, protective, connective tissue outer wrapping. So the epiphysis, typically on the outer surface of the epiphysis, has a thin layer of hyaline cartilage. This is what's called the articular cartilage. And this covers the bone to basically reduce wear and tear on the bone. That's in the joints, as your joints basically kind of bear the load that they're designed to bear. Sometimes we'll see also another region in the bone itself called the metaphysis. And so the metaphysis is typically this little region right in here, just between the epiphysis and the diaphysis. So it's basically this kind of region right in here. There's like a little transition zone in there before you get to the epiphysis, which is more like the end piece of the actual bone itself. And the metaphysis, or the metaphysis, basically is going to have what's called the epiphyseal plate. So this is essentially the growth plate, which is a region of cartilage when we're growing that then turns into bone when we stop growing. And then, of course, we saw the periosteum. And that's going to be that outer wrapping of connective tissue that wraps the outside of the bones. And what this does is it basically connects the bones with your ligaments and your tendons. So it basically interweaves with them. And so that's basically how ligaments and tendons basically connect to the bone. Now, when you're taking a look at bone, we did talk a little bit about this. So I want to move quickly, right? So we have two different types of bone, compact and spongy, where the compact bone is organized into these circular structures called osteons that are large concentric circles of what's called lamella or bony tissue that is surrounding a central canal. So basically, they have a central canal with a blood vessel in it, and then your bony osteocytes, right? These are bone cells. So osteo means bone, cyte means cell. So these are bone cells that start to lay down concentric rings of bony matrix. And so your central canal is in the middle, and then typically you'll have little osteocytes that are trapped in the bony matrix, but they kind of create a little carve out or a little hollowing for themselves called the lacuna. So this is basically the hollow area. It's like a little hole, like a little cavity that your osteocyte lives in. And so that's your osteon. And so the matrix basically fills the space in between these rows of lacuna. So this is kind of what it looks like. So here you can see the inner layer where you have your medullary cavity. This is your periosteum, that outer wrapping of connective tissue. And here you can see the osteon. So like, for instance, this is an actual micrograph of an osteon. So you can see here this central canal where the blood vessel is. You can see these like little, looks like tree rings of lamellar growth that basically is one layer on top of another. And these little dark spots are the osteocytes inside the lacuna. So for instance, here's a blow up of that image. You can see this green guy right here is your osteocyte. That's your bone cell. And then you can see your lacuna is this open space, this open cavity that the osteocyte lives in. And then over here, you can see this is the bony matrix outside. Now, you can also see these lateral lines, almost look like cracks. Those aren't cracks. Those are what's called canaliculi. These are basically small channels that connect the osteocytes to the central canal. And that's to get blood to them. So the cartoon image is really, really good. So you can see here's one osteocyte with its concentric rings wrapped around the blood vessels in the central canal. And you can see here they pulled out each of these layers. So here's the first inner layer that's laid down, the second layer that's laid down, the third layer that's laid down. And then smacked in the middle of those layers, sandwiched between the layers, are these little osteocytes that are trapped in their little lacuna. If you take a look at it from the side, you can see that these central canals are long and cylindrical. So basically they run the length of your bone. And then every now and then you'll have these little cross channels that connects one osteon to the next. So you can see they're all interconnected with each other and they're all highly vascular. So the canaliculi basically will connect one layer to another, and they'll also connect the cells to the central canal. This basically allows for blood delivery to the osteocytes. Because remember, the osteocytes are living cells. They need nourishment too. They need oxygen and nutrients too. And so this is basically how they connect to that oxygen and nutrients. And so they kind of interconnect with each other. And so that's basically what's happening there. Spongy bone is a little bit different. Spongy bone looks like a sponge, right? So basically what they have is little ribs of bone called trabecula. And so they oftentimes are a little bit lighter than compact bone. because they've got a lot of open space in between these little trabecular ribs. But it's still designed for strength. So it still can provide strength, just it's not as tight and compact as compact bone. Within the little nooks and crannies or the spaces of the spongy bone, you're going to find red bone marrow, which is basically the site where all of your red blood cells and white blood cells are being made. And so your red marrow is very, very critical to your immune system. So the osteocytes in spongy bone are just kind of peppered within the trabecula, and their job is to maintain the bony matrix of the actual bone itself. So that's the structure of your bone, compact and spongy. Now, in terms of cartilage, cartilage is going to be maintained by chondrocytes. So chondro refers to cartilage, cyte means cell, so this actually means cartilage cell. And so cartilage is not as strong as bone, has more flexibility to it. It contains a lot of collagen for that flexibility and elastic fibers. That gives it flexibility. And your chondrocytes have a similar type of an organization to the osteocytes in the sense that your cartilage cells, your chondrocytes, live within these little hollow areas called lacuna, just like your osteocytes do. The difference between cartilage and bone, however, is that where bone is very vascular and has lots of nerve to it, cartilage does not have any nerves or blood vessels. It's avascular. And so the way it gets nutrients is by diffusion from nearby tissues. So during diffusion. And so this makes it very difficult, very slow to heal. It also limits the size of the cartilage. So you don't have large swaths of cartilage because you don't have the vasculature to support those cells. You have 3 different types of cartilage. You have your hyaline, your fibro, and your elastic cartilage. And so if you recall from chapter 4, your hyaline cartilage is typically at the end of your long bones in your articulations. So that's your articular cartilage. Your nose is a type of cartilage. Your ribs, there's costal cartilage in your ribs, in your larynx, and your trachea. You have tracheal cartilage. Those are the rings on the front of your throat. That's tracheal cartilage. So you have lots of hyaline cartilage. That's actually the majority of your cartilage. It's the most common cartilage. You have fibrocartilage in a couple of major places. For instance, in the discs in your vertebra, you do have fibrocartilage in the meniscus of your knee. And so those are 2 major areas. So this is basically for shock absorption. That's usually why you have fibrocartilage in there. It's like a shock absorber pad. And then elastic cartilage, you have a little bit of that. Your epiglottis is elastic cartilage. We looked at that one earlier when we looked at the digestive system. And then your ear flaps, your ear itself is also elastic cartilage. So these are examples of the different types of cartilage. When you take a look then at the nature of the connective tissues being laid down, the cells that are behind laying down this fibrous connective tissue are the fibroblasts. So these are basically the cells that will essentially lay down connective tissue. And this collagenous fiber network is mostly what your ligaments are and your tendons are. For instance, if you want to know what pure collagen looks like, grab a hold of your Achilles tendon, the back of your heel. That's almost pure collagen there, right? So your ligaments are responsible for connecting bones to bones. So this is bone to bone. And they typically will do this at joints. And then tendons will connect muscle to bone, also at a joint. And this is called an articulation. So when a muscle connects over a joint, that's called an articulation. You're articulating one muscle or one bone to another. Okay, so let's go ahead and take a look at the bones of our axial skeleton. So we have 206 bones of the skeleton so far. We can classify them in 2 major groupings, the axial skeleton and the appendicular skeleton. That is to say, the axial skeleton is associated with the midline. It consists of your skull and all the bones in it, your hyoid, which is a free-floating bone just underneath your chin, your vertebral column, and of course your rib cage. So these are all parts of your axial skeleton. They run down the midline. Your appendicular skeleton is going to be the appendages, like your arms and legs. Okay, so this is kind of what it looks like. So you can see in blue is your axial skeleton. You got your skull, your rib cage, and your vertebra, pretty much both front and back. So this is your anterior view, and this is your posterior view of your axial skeleton. And so the skull is basically going to be your cranium, that is to say your brain case, and of course your facial bones, the bones of your face. Now, some of the cranial bones will contribute to the face and some will not, but we'll take a look at those. So the cranium, the skull bones basically exist, and their job is to protect the brain from insults. So like if you hit your head, then you're not going to damage your brain. So it's basically a gigantic helmet that you're wearing. And so in adults, we have 8 cranial bones that are in our skull that fuse together. They are basically fused with what's called sutural joints. But when we are first born, these bones have not yet fused together. And so they create these little unfused areas called fontanelles, the so-called soft spots in our skulls. That's basically just skull bones that haven't fused together yet into a uniform, tight, strong case. And the reason for that is they exist to allow birth to occur in the head, in particular, to fit through the birth canal. So when the baby is being born head first, because the fontanelles haven't completely connected the skull bones together, the head is able to distort and kind of crumple, crush, if you will, so that the baby can kind of scooch through the birth canal. It's a tight fit, but the baby can get through there. If these skull bones had already fused together, then the baby's head would not be able to change shape, and the baby would not fit through the birth canal. Basically, it would probably kill the mother during birth, and it would probably kill the baby as well. So right after birth, these close up pretty quickly, and then the skull is completely fused together. So the bones of the cranium. So we have several of them. So first of all, we have what's called the frontal bone, and I want to take a look at this in context. So the frontal bone is basically going to be the bone associated with your forehead. And then we're going to have the parietal bones, which is the top of the head. So that's basically these large areas, both right and left on the side of your head. So at the very top or the crown of your head, that's going to be your parietals. Your occipital is going to be the back. So if you grab the back of your head, that's your occipital bone. Your temporal bone is the one right over your ear. So here is what's called the external auditory canal, which is the external ear canal. And so your ear is basically right here. And so this temporal bone is basically right over your ear. And then the sphenoid bone, which is kind of a hard one to find because it's kind of inside your head a little bit. But the sphenoid bone is just in front of your temporal bone. And it's basically right about where your temples are. So if you put your finger on your temples, that's about where your sphenoid bone is. And your ethmoid bone is part of your nasal cavity. So basically your ethmoid bone, which is this piece right here, is actually forming a good portion of your nasal cavity. Now, within the skull itself, you got a large hole called the foramen magnum. And in the foramen magnum, your spinal cord passes through there. So you can see the foramen magnum here in this large open area. So that's where your spinal cord is coming through. And this upside down, we kind of turn the skull over. You can see the purple sphenoid bone. So that's your sphenoid, kind of looks like a bat a little bit. You can also see the occipital bone much better. That's this kind of lighter purple color, or more fuchsia, I guess. I don't know what your colors are. But your external auditory canal is essentially inside the temporal bone, and it leads to your middle ear. Your middle ear is actually encased inside your temporal bone, so it's protected in there. And so the sphenoid will come together. It'll form the sides of the skull, fitting together your zygomatic, which is basically your cheekbone. So you can see the green one here is your zygomatic. That's your cheekbone. So when you touch your cheekbone, you're touching your zygomatic. And sandwiched in between those two is your sphenoid, which connects your temporal to your zygomatic. It also forms, actually, many of your skull bones will actually form the orbit of your eye. So if you take your eye out, you actually see multiple skull bones coming together to form the orbit of your eye. And of course, the ethmoid basically is your nasal septum and the bulk of your nasal cavity. So those are the skull bones. Within some of your skull bones, you have what's called sinuses. So sinuses are essentially air spaces in some of the cranial bones. And oftentimes they are lined with mucous membranes, so they will basically increase in mucus. And what this does is it reduces the weight of the skull, so it's easier to carry. Not so much work to do there to hold your head up. And also they can do sound resonance, right? So we can actually, the reason why our voice sounds different when we talk versus when we hear ourselves played back is partly because what we hear is the sound of our voice resonating through our sinuses. So it sounds one way in our head, but it sounds completely differently when we hear it played back to us. And the sinuses typically tend to be named after the bones they're in. For instance, in the frontal bone, you have a frontal sinus, the sphenoid bone, you have sphenoid sinus, ethmoid sinuses, and maxillary sinuses. And so these are basically named after their bones. You have several of them, and there's a smaller set of sinuses. These are the big ones, right? These are the ones that hurt. Like when you have a headache and it's right here in the front of your skull, like on your frontal bone, that's your frontal sinuses. When you have the ones that are kind of like feel like they're right underneath your eye, that's your maxillary sinuses. And so their pressure can be created by this mucus, and that creates a headache. So there are smaller sinuses in the mastoid, which basically will drain into the middle ear. The mastoid is actually part of the temporal bone. So for instance, if you take a look at this large bony structure right here, that's what's called the mastoid process. So there's little sinuses in there that help to drain the middle ear. The mastoid process, if you basically put your finger right behind your ear, that little piece of bone that's right there, that's your mastoid process. That's part of your temporal bone. So if you have an inflammation of this region, right, you'll have an inflammation of that particular sinus in there. Okay, let's take a look at the facial bones. So the bones of the face. So first of all, we have the mandible, which is your lower jaw, the maxilla, which is your upper jaw, and the zygomatic, which is your cheekbone, and then your nasal bones, which are basically right between your eyes. So of these, only the mandible is movable. The maxilla, which is your upper jaw, stays put, and it actually forms part of your eye orbit as well. It also forms the front part of your hard palate and the floor of the nose, right? So basically the hard palate is between your oral cavity and your nasal cavity. And that's your maxilla, forming that hard palate. On the back side of the hard palate, you also have another skull bone called the palatine. This forms the back half of the hard palate. And then the zygomatic bones curve around the front and they form the cheekbones. So here's kind of what it looks like. So here's your zygomatic. You can see basically it's forming the cheekbones here and also the edge of your eye orbit. The maxilla is basically going to form part of your nasal area. Seeing it's going into the eye orbit as well. The mandible is the one that we move up and down to chew. And then the nasal bones, which are these purple guys right here in the middle, form our nasal bridge. Okay. Continuation. So the nasal bones, like I said, form the bridge of the nose. Other bones that are involved in here, for instance, the ethmoid and the vomer, are also part of the nasal septum that divides one half of your nasal cavity from the other. And also the lacrimal bone, which basically is kind of right in by your tear duct. This basically forms an opening called the nasolacrimal canal, which is your tear duct. And that drains tears from your eyes into your nasal cavity. So basically the lacrimal bone, if I draw it in isolation, looks like a little small piece of bone, but it's got this like little groove in there. And that little groove basically sits right at the bottom of your tear duct in your eye. And on the bottom of this is your nasal cavity. So the tears will drain down your lacrimal duct into your nasal cavity, which is the reason why we get snotty when we cry. Is because that tear duct is connected to our nasal cavity. The hyoid bone is not actually part of the skull, but is part of the axial skeleton. This is the only bone in the body that does not articulate with another bone. Basically, it floats free. Every other bone in your body is bound to another bone. Now, what the hyoid does is it basically acts like an attachment point for your tongue and also for a lot of muscles for swallowing. So ultimately, oftentimes, if you fracture your hyoid, this can cause strangulation because those muscles aren't able to pull on your hyoid. So what you have basically is this kind of like this hyoid bone, which kind of looks like a little boomerang. But what you have is basically muscles that are attached to them, to the hyoid. And these aren't actual specific, they're just like this. I'm just drawing examples. They're not actually anatomically correct. But they're basically strung up in between. So the hyoid is basically kind of like hovering between all these muscles, and the muscles are using the hyoid as an attachment point as they kind of counterbalance each other. If you break it, then those muscles can't actually work properly, and it could cause you to actually strangle, the kind of manual strangulation, essentially. When you get that broken hyoid, your muscles can't work, and so your throat muscles, which are involved in swallowing and things like that, aren't able to actually work properly. Let's take a look at the vertebral column. So you basically have 33 vertebrae. And then when you take a look at all these different vertebrae, you have 3 different types. You have cervical, thoracic, and lumbar vertebra. And these are the ones that essentially will create the curvature of your back and the actual fluid flow of the movement of your back as well. And then you have a couple of different disorders. Obviously, if this isn't working, this abnormal curvature of the back, we have different types of abnormal curvatures. One that we have is scoliosis, where essentially we kind of have an abnormal sideways curvature of the spine. The spine is supposed to be kind of straight like that, but if you have an S-like curve, that's scoliosis. Kyphosis is the hunchback. So this is basically you're supposed to have a little bit of kind of a hunch like that, and your spine goes in like that. But if you have an excessive hunch like that, then your spine looks more like a question mark. And then lordosis is another abnormal. This is the sway back one. So this is where you're kind of doing the opposite one, where you have a normal curvature at the top, but you have like an excessive deep incline. So that's your sway back, right? So this is the abnormal piece. So this is your head up at the top. So my head up here, there's my nose, my mouth, my eyes. Okay, and my hair. Yeah, okay. So those are some major curvatures. So here's what it looks like. So you have basically this kind of nice, structure. So you have 7 cervicals, which you see C1 or listed as C1 through C7. And then your thoracics are going to go down to 12. So you have 12 thoracics. So that is to say T1 down to T12. And then the lumbars, you've got 5 of those, L1 to L5. And so these are the ones supporting your lower back. And then at the very tip of your spinal cord, you've got what's called your sacrum, which is 5 fused vertebrae. There's 5 vertebrae in there that are fused together. And your sacrum basically will form this large kind of structure, this pan-like structure with a little tip on it, your coccyx, which are 4 fused vertebrae that have been fused together. And so that's basically your tailbone, your coccyx. So when you take a look at the vertebral column, you'll see a couple of major features associated with the vertebral column. The first one is your vertebral canal. So this is basically the center of the column where your spinal cord will pass through it. You also have foramina. So basically these means little holes. That's what they mean. On each side of the column, this is for spinal nerves to travel through. So your spinal nerves go lateral. So your spinal cord goes down like this. Your spinal nerves start to shoot out laterally throughout your body. So that's where the spinal nerves go. And so the spinal nerves are the ones controlling your skeletal muscles for contraction purposes. And so if these guys are injured, this is what will create paralysis. Or if it's bad enough, if it's controlling enough things that you can't live without, then it'll create death. You'll die from it as well. A couple of more structures associated with the vertebral column. Your spinous process are bony projections that kind of stick out of the top of the vertebral column along the midline of the back. And so these are the little bumps that you can feel along your vertebral column. And the transverse processes, which stick out to the side, they extend laterally. These guys are always for muscle attachment. So a lot of those postural muscles that you need in your back are attached to the spinous and the transverse process. There's 2 very special cervical vertebrae that we have special names for. The atlas, which is C1, that's the very first one. This articulates to your skull, right? So this is your first cervical vertebra. Hold your head up, and basically it articulates with the occipital bone in the skull. So that's the first one. And then C2 is what's called the axis. This is your second cervical vertebra. And it's so named because one of the structures that it has is a long process called the odontoid process along the long axis. So when we shake our head no, it basically allows a pivot. So if you take a look at the axis basically has a process that sticks up like this that allows you to be able to pivot around that process. And that's why it's called the axis. So here's basically how your vertebra looks. So essentially you have a couple of major pieces. Number one, you have the body, which is the main region of the vertebra itself. On the edges, you'll see these long sort of extensions, the spinous process, which essentially is for musculature. On the edges, the sides, these guys right here and right here are the transverse processes. These are sticking out laterally. On the middle, you'll see an open hole. This is your vertebral canal, where the spinal cord is going through. And then as you put this together, you'll see these like little kind of hollowed out pieces called facets. This is what's called a superior articular facet. And this is typically where the next vertebra will kind of drop in. So it's articulating with the next vertebra. And then as you put them together, you'll notice these like little itty bitty indentations, especially in the thoracics, right? And this is basically your articulation for your ribs. This is where your ribs will actually touch your spinal cord, along with these little facets right here on the side. So your ribs will basically come in like this. So they'll kind of come in, they'll attach here, and they'll kind of move out like that to the rest of the body. Okay, now the discs, right? The stuff that's in between the vertebra. So these are going to be your fibrocartilage plugs. And so what happens is these prevent the vertebra from grinding bone on bone. So they're purely for shock absorption, like we talked about earlier. And so when you guys jump or you move, you're not going to have that vertebra on vertebra bone grinding, which would be incredibly painful. And so this allows us to have comfortable movement. We can bend forward, backward, side to side without having bone on bone contact. And so those are important. So if they become weak, like for instance, as we get older, our cartilage starts to break down, or they can herniate and rupture, then what that means is basically this will cause our disc to press against the spinal cord. It'll bulge and press against the spinal cord, and that hurts. And so we'll feel that as nervous pain. So let's go take a look at the rib cage now. So the rib cage, or the thoracic cage, is essentially thoracic vertebra with your ribs in their associated articulations with the thoracic vertebra. So this is part of your axial skeleton, and it's going to be protecting and wrapping around the heart and the lungs, your thoracic cavity. And it swings outward and upward when you inhale so that you can expand your rib cage. So here's what it looks like. So basically we have our sternum, which is kind of holding our rib cage together. Our ribs go back and they articulate with the vertebra. You can see those in the back. And they're connected to the sternum with costal cartilage. So this costal cartilage is basically the connector from the ends of the ribs to the actual sternum. And then this will give you a little bit of flexibility so that you can expand your chest. Now your sternum is made up of a couple of different regions. For instance, you have the manubrium, which is this like badge-like structure at the upper portion of your sternum. Then you have what's called the sternal angle, and then you have the body of the sternum down here, which is your chest bone proper. And then at the very bottom, you have your xiphoid process, which is a little piece of bone that sticks off the end of the sternum to which muscles will attach. And so you have 7 what's called true ribs. True because basically all 7 of them, I'll take rib number 7 here, that they all basically connect to the sternum. And then you have what's called false ribs. So these ribs don't connect to the sternum, they connect to the costal cartilage. So these are the false ones. And then you have floating ribs, right? So floating ribs basically are just kind of like out there. They're not really connected to the rest of the rib cage. They're just kind of floating out there. And so that's how your rib cage is oriented. So you have 12 different pairs, and they basically will connect to the thoracic vertebra directly. But the transverse processes are essentially where these ribs will articulate to. They'll attach to the transverse processes. And then they curve outward and then forward. And then, of course, we said the true ribs are 1 through 7 because they are connected to the costal cartilage directly to the sternum. And then the false ribs, because they do not connect directly to the sternum. And then the floating ribs, which is 11 and 12, because they don't have any connection to the sternum at all. Okay, now let's take a look at the sternum. All right, so this is your chest or breastbone right in the middle. So you have the upper portion, which is the manubrium. That's the badge-like piece, followed by the body. And then below that is the xiphoid process. The manubrium will articulate with your clavicles, which are essentially your collarbones, which then goes out to your shoulders. And it also will join to the body of the sternum at what's called the sternal angle. And then that will basically form the entirety of your breastbone. And so it has a little bit of flexibility to it, so your rib cage can expand while you're breathing. And so ultimately, it's there basically to kind of provide structure and a bonding spot for your ribs to actually bind to in the front. Okay. So the xiphoid process essentially is where your diaphragm will attach to, which is associated with your respiratory system. And so your diaphragm will attach to the xiphoid process and to use that as leverage as it begins to open up the thoracic cavity during the breathing mechanism. Okay. So that's the axial skeleton. Let's go ahead and take a look at the appendicular skeleton. So this is essentially bones of the pectoral and the pelvic girdles, that is to say your shoulders and your hips. And so this is going to be your upper limb. Your pectoral girdle is associated with your upper limb to give you upper limb mobility and flexibility, and your hip girdle or your pelvic girdle is for your lower limbs to give you strength and support. So your pectoral girdle is much, much more malleable, and it can move much better than your hip girdle. So what's in your pectoral girdle? You have a couple of things. First of all, your scapula or your shoulder blade, and your clavicle, which is your collarbone. So your clavicle will extend across the top. So you can kind of feel that where your collarbone is, and it'll join on the inner portion to your sternum. And then on the outer portion, it'll actually join to your acromial process, which is essentially your shoulder. So typically the muscles of the arm and the chest will attach to what's called the coracoid process of the scapula. So the scapula, if you take a look at it, has a couple of different things here. For instance, the coracoid process is going to be this guy right here. And then your acromion is this guy right there. Acromion is basically your shoulder. The coracoid is where a lot of these muscles will attach. And then within the scapula, you have what's called the glenoid cavity. And the glenoid cavity is basically the bowl that articulates with the head of the humerus to form your arm joint. Your shoulder joint is a ball and socket. And the ball is the head of the humerus. The socket is the glenoid cavity. So your shoulder joint is very, very mobile. But the problem is it's also very unstable, right? It's basically held together with tendons and ligaments. So it can dislocate very easily, right? So your tendons and your ligaments are what stabilizes it. As a matter of fact, you also have some muscles that stabilize it. We have a group of muscles called the rotator cuff. So these are muscles. There's a group of 4 muscles that stabilize the joint. And we call those collectively the rotator cuff. And so the tendons of these muscles will help to stabilize and keep your shoulder from dislocating. And so they'll hold that humerus inside that glenoid cavity. So for instance, if you have very strong circular movements of your arm, like a baseball pitch, then you can create damage to these muscles and to the tendons of these muscles, and that would be a rotator cuff injury. And so with all pitchers having rotator cuff issues all the time, so it's a common one. So here's kind of what it looks like. You can see the head of the humerus here. So here is the glenoid cavity. You can see that shallow little bowl right there. And you have the head of the humerus right there, which is snuggling into the actual bowl. And so you have your rotator cuff muscles attaching and holding your humerus into the glenoid cavity. Now, as you start to move, your pectoral girdle will be basically a combination of your scapula and your clavicle. The upper limb then is basically, as we move away from the shoulder joint down your arm, you get your upper arm, which is basically all humerus, your forearm, which is a combination of radius and ulna. You've got 2 lower arms bones there. In your hand, you got a few bones, right? So you have your wrist bones and the carpals, your metacarpals, which are your hand bones, and then your phalanges, which are your finger bones. And so if you kind of go down, you can see this here is your humerus. We put H for humerus. And then you have your radius and your ulna. So your ulna and your radius in your lower arm. And then you see your carpals here, your metacarpals here, and then your phalanges at the tips of your fingers. Okay, so in terms of upper limb, the humerus is in the upper arm, and then the radius and ulna are in the forearm, giving you forearm movement. The humerus is a single long bone, and it has pretty much a smooth, rounded head that fits into the glenoid cavity of the scapula. And then the shaft of the humerus has a tuberosity or a protuberance, right? That's basically this guy right here, this little bump right there. That is called a tuberosity. Tuberosity is an A&P term for a bump of some structure. And this is where your deltoid, or your shoulder muscle, attaches. This is the one that you get shots in when you get vaccinations. So if you take a look at your muscles, your deltoid basically would start up here, and then it'd basically attach right about there. So this would be your deltoid, your shoulder muscle. So at the far end of the humerus, you have two articulation structures, protuberances, if you will. One called the capitulum, and the other one called the trochlea. And this is basically where you are articulating with the radius. So the radius is articulating with the capitulum, and the ulna is articulating with the trochlea, and that's happening at the elbow. So these four connect together to form the elbow joint. Now, at the back of the ulna is going to be another bump of a structure, or the bend of the elbow. This is called the olecranon process. This is essentially the elbow. So your elbow that you lean on is essentially your olecranon. So you can see then from our image, the trochlea is this kind of odd-shaped sort of T-looking thing. So that's your trochlea. That's articulating with the ulna. And the capitulum is articulating with the head of the radius. Now you can see these like little depressions right here. These are what's called fossa that are designed to fold up and allow the ulna to basically fit right into that little area. So it kind of makes a little area there for the when you bend your elbow for it to fit in there. So in the hand, you have 8 wrist bones or carpal bones. You have 5 metacarpal bones, that is to say, bones of the palm or the back of the hand, depending on how you look at it. And so the metacarpal that goes to the thumb is opposable to the fingers. That basically means you can touch the thumb to the tip of the finger. The knuckles, the big knuckles, are essentially the enlarged ends of the metacarpals. And then from the metacarpals, you'll get to the phalanges, which are essentially the bones of the fingers. They're short. And they form your other knuckles. So you're 1 and 2. So you have 1, 2, 3 phalanges per finger. That we refer to as distal, middle, and proximal fingers, going from outside in toward your body, toward your hand. Okay. So the pelvic girdle that we have, which is your hip girdle, consists of a couple things, right? First of all, the coxal bones, which are the hip bones proper, and the pelvis, which is associated with the pelvic girdle. You're going to add the sacrum and the coccyx in there as well. We'll take a look at what that looks like here in just a second. This is designed to bear weight. Remember, the pectoral girdle is designed to move and to give you flexibility in your upper body. This one is designed to bear your weight. It also is going to be protecting your organs. Your pelvic cavity, for instance, where your reproductive organs are, it's going to be protected by your pelvic girdle, and it'll allow you attachment for your legs. So the coxal bone has 3 basic pieces. There's 3 major bones in your hip. The first one is the ilium. The second one is the ischium. And the third one is the pubis. And they're typically fused together in an adult to create a bowl-like structure. Now, where these 3 converge, they converge at a point called the acetabulum. So basically, acetabulum, what an acetabulum was back in Rome, it's actually a thing, is an acetabulum was a little bowl that Romans used to use to put vinegar in to dip their bread. And so what we have is a little bowl-like socket that we use where both ilium, ischium, and pubis meet, and it creates this little bowl-like structure, the socket, which is the socket portion of your ball and socket joint, which takes in the head of your femur. So ultimately, the bone that we sit on is our ischium, and our pubic bone projects forward. And so the ischium will have a posterior spine called the ischial spine, and this will have muscle attachment, for instance, your gluteal muscles and so forth. There are two pubic bones. Typically, they are separated by a fibrocartilaginous plug called the pubic symphysis. This prevents the pubic bones from clapping together when we take a step. So it's there to protect us. So here's kind of what it looks like. So here's our hip girdle. So we have our ilium up here at the top, our ischium, which is the one we sit on, and then forward we have our pubic. You can see that little plug right there. That's the pubic symphysis. It's a little fibrocartilaginous plug to separate the two pubic bones so they're not hitting each other. The acetabulum, where all three bones come together, is the little bowl-like structure that will take the head of the femur in this ball and socket joint. You have a little bit of a neck, which kind of pushes your femur out laterally. So your legs are to the side, not just underneath you. And then, of course, you have your femur. Now, let's go ahead and take a look as we get down to the lower limb portion. So we first move to the thigh, which is the femur, and then the lower leg, which is the tibia and the fibula. And then the foot is composed of the tarsals, the metatarsals, which are the arch bones, and the phalanges, which are the toe bones. The tarsals are your ankle bones. And so when you take a look at each of these guys, we'll see these in our image. But when you take a look at the pelvis versus the female pelvis, you can actually tell male, female based on their pelvis. Because in a female, generally speaking, the iliac bones, that is to say the bowl, the edge of the bowl, are more flared, and the pelvic cavity is typically more shallow. So basically it's broader in circumference and it's shallower in depth. And the pelvic opening is wider. All of these will facilitate the birthing process. Okay. So then when we get to the lower limb, we start with our femur, and we'll go to the tibia and the fibula. So the femur is the longest and strongest bone in your body. This is the heavy lifter. The head of the femur will articulate into the acetabulum to create your ball and socket joint. Of course, it's held in there by ligaments and tendons. And so this basically will position you for walking. The femur has two large processes, both greater and lesser trochanters. And these are attachments for your thigh muscles and also for your gluteal muscles and your hip flexors. So if you take a look at your femur, you'll typically see the greater trochanter and the lesser. Those are attachments. Then as we head distal, we get kind of down toward the knee. The femur will have what's called medial and lateral condyles. These are basically bumps on the sides of the bones, and these are going to be articulating with the tibia. So if we take a look at the medial and lateral condyles, we'll see this guy right here and this guy right here. So this is going to be the medial condyle, and this one will be the lateral condyle. And these will be articulating specifically to the tibia. So you can see the tibia is basically locking into it just below it. Now then, we take a look at the patella. The patella is a kneecap. And so this is basically held in place by your quadriceps tendon. So your quad group basically wraps over your patella and holds it on top of your knee. And then it'll actually continue as a ligament and attach your patella to the tibial tuberosity, which is that little bump of bone just above the tibia, just at the top portion of the tibia. At the bottom portion of the distal end of the tibia, you'll have what's called a medial malleolus. So this is a bump area in the tibia that forms the inside ankle. So that little bump on the inside of your ankle is the medial malleolus of your tibia. Your fibula, which runs alongside your tibia, has a fibular head that articulates with the tibia at the knee. And then distally, it'll articulate with the tibia. And then it'll form the lateral malleolus, which is the little bump in your ankle on the outside of your ankle. This is basically the lateral malleolus. This is what it looks like. So here basically is your tibial tuberosity, that little ridge right there. Then as you go down, this guy right here is going to be your medial malleolus. That's the inside of your ankle. And this little piece right here is going to be your lateral malleolus of your fibula. Now, as we start to move into the foot, we're going to get into the tarsal bones. You have 7 tarsal bones or ankle bones. The talus is the top one. This is where your tibia articulates with the and the fibula articulates with the ankle. The heel bone is your calcaneus. So the talus and this sits on top of the calcaneus. So basically the talus so together these two, so you have your talus basically on top of your calcaneus, and then you have your fibula and your tibia resting right on top of that. So these basically will be supporting your body weight. So it's your talus and your calcaneus. Then the instep bones are your metatarsal bones. And then, of course, the bones of your toes are your phalanges. So here's what it looks like. So this is your talus, so this guy right here. And then below that, I don't think you can see the heel bone because it's behind the foot, but this is your talus. You can see how your talus basically is fitting, is your tibia is resting right on top of your talus. So this is where the bulk of that body weight is resting on. And then, of course, you have your toe bones and your phalanges. And those would be your metatarsals here, and then your phalanges here. Okay. Now let's take a look at articulations. Articulations basically is a fancy word for joints. So this is basically where your bones are coming together. And so you have a couple of different types of joints. You have what's called fibrous joints, cartilaginous joints, or synovial joints. Most of the fibrous joints are immovable. So for instance, skull sutures are immovable cranial joints. Cartilaginous joints typically are usually connected by hyaline cartilage. That is like costal cartilage connecting your ribs, or fiber cartilage, for instance, in your vertebral discs. These might have some movement, but not a lot. These aren't designed to really move. And the synovial joints are the movable ones. So these are basically the dominant ones. For ambulation. So here's what a synovial joint looks like. So most of the joints that we endure, like skiing or playing sports, something like that, are synovial joints. And so this is kind of how it looks. So here's an example of a generalized synovial joint. This is your knee joint. First of all, you'll notice, number one, your articular cartilage is just wrapping around your joint itself. Generally speaking, a synovial joint is typified by a joint cavity that's filled with synovial fluid. And so what will happen is you'll have basically a structure, a membrane, synovial membrane, that will essentially close this joint, giving it a cavity full of fluid, slippery, lubricating fluid to make sure everything moves very easily. And then in your knee joint, oftentimes you'll have different types of connective tissue. So for instance, you'll have fibrocartilage connective tissue, like the knee meniscus, plugged in between to kind of reduce the impact of your femur banging against your tibia. Then you'll also have ligaments connecting your femur and your tibia together. So these are ligaments that'll be connecting the bone to the bone. And then in addition to that, you'll also have what's called bursa, which are little fluid-filled sacs. And these are basically for padding. and friction reduction. So you'll have these little bursa in here, like for instance, a muscle would lay on top of that. And so instead of allowing your muscle to chafe on the underlying bone, you put a bursa in there to kind of reduce the amount of friction. So that's what your knee joint looks like. So your shoulder joint looks very similar. So you can see how you have this sort of ball and socket approach to it. And then your elbow joint is like a hinge joint. So you have different types of joints. So basically, when you take a look at the synovial joints, the things that we have are the joint capsule, which is formed typically by ligaments. It surrounds the joint and protects it and closes it. Then we have the synovial membrane, which lines the joint capsule and secretes synovial fluid for lubrication and nutrition. The bursa, these basically are these fluid-filled sacs to ease friction. The meniscus, which is a fibrocartilage plug that is a shock absorber. And then you'll see these in your joints. So the common types of synovial joints we see are the ball and socket joints, where you essentially have rotational movement in all planes, that is to say in the XYZ plane. And then the hinge joints, which typically are only in one direction, like your elbow and your knee, are types of hinge joints, but they're also synovial joints. So the different types of movement that you can produce by your synovial joints typically gives you a sense of range of motion based on how your joints are put together. So for instance, when your muscles contract, one bone moves relative to another, and it gives you a range of motion. Typically, these ranges of motion will go together. So for instance, you have flexion and extension. So when you flex your arm, you're basically bending it up. When you extend it, you're basically bending it out. Flexion of your knee, you're essentially bending your knee inward. And an extension is when you extend your knee straight out. You have abduction and adduction. Adduction is anytime you move like your arm or your leg toward your midline. Abduction is when you move it away. So I think of abduct as abducting somebody to take somebody away. You're moving something away from your body line. Then you have different types of rotational movement. So for instance, if you were to take your leg and essentially at your ball and socket joint, just rotate your ball and socket joint, not your knee, and just draw a circle with your toe in the air, that's called circumduction. That's a type of rotation. Supination is basically when you're twisting your hand to be face down, versus pronation is when, other way around. Supination is when you are twisting your hand to be face up. Face is anterior, so basically face up. And pronation is when it's face down. And then basic rotation is anytime you're kind of rotating in a circle. For instance, your elbow, you can rotate your elbow a little bit. So inversion is when the sole of your foot points toward the inside of your body. Eversion is when the sole of your foot points toward the outside of your body. And depending on how we walk, sometimes we have a gait that's inverted or everted. Okay, now let's take a look at bone growth, and then we'll take a look at bone repair. So first of all, when we take a look at bone growth and homeostasis, the first thing to understand is that the ones in charge of bone growth are the osteoblasts, or these are developmental cells that will essentially lay down new bony matrix. And so they'll excrete or secrete this bony matrix of the bone, and then they'll deposit calcium salts into the matrix, which hardens it. And that's what your calcium salt will do. Then what happens is they mature into osteocytes, which are mature bones. And so these guys will be the ones that surround themselves with their lacuta, and their job is to maintain existing matrix. So osteoblasts lay down new matrix, osteocytes maintain existing matrix, and the last one is we have osteocytes, osteoclasts. Osteoclasts are basically bone absorbing cells. So what these guys do is they basically break down And when they break down bony matrix, they basically release the calcium and the phosphate. And typically that'll go into the bloodstream. And so they're constantly removing bony matrix. And then the osteoblast will build it up. So there's this kind of give and take. Osteoblasts will lay down bony matrix, osteoclasts will tear it down. So there's kind of this balance between the two. Now, when we get into bone growth and development, what we're talking about is ossification, which simply means that it's the formation of bone. Now, the bones basically form during embryonic development, and there's two different patterns that we see in bone growth. One is called intramembranous ossification, the other one is called endochondral ossification. So let's take a look at intramembranous first. So in intramembranous, this is basically the formation of flat bones. A good example of those is your skull bones. Your skull bones are flat bones. So these bones will basically develop between sheets of fibrous connective tissue. And so what will happen, essentially the bones, the osteoblasts, start laying down matrix within the connective tissue. And then they'll also start to carry out further ossification from the periosteum, because there's osteoblasts at that liner on the outside of the bone. And then what happens is the trabecula form, and then they fuse into compact bone, which then surrounds the spongy bone inside. So you just basically start making stuff like right where you are inside the connective tissue. Endochondral ossification is a little bit different. This basically is forming most of your long bones, like your tibia and your femur. So what happens here is you start with a cartilaginous skeleton that then gets replaced by bony matrix. Okay, and so this hyaline cartilage forms your skeleton back when you're a developmenting fetus. And then that cartilage will be replaced by bone. So ultimately, it starts to replace cartilage with bone, and it starts to spread from one center of bone to the next. And this gives us our cartilage model, right? So the idea is, in the embryo, we start off first by chondrocytes creating a cartilaginous skeleton made out of hyaline cartilage. And it's essentially kind of a mock prototype of your future skeleton. So before your femur becomes your femur, it actually becomes a little cartilaginous prototype when you are a fetus. Then what happens is osteoblasts will start to secrete bony matrix on the outside, which then calcifies, creating a bony collar. And this bony collar, which is compact bone, covers the diaphysis. That's where that bony collar is. It covers the diaphysis. So when we take a look at the process of endochondral ossification, the first thing that has to happen is we have to start with our first primary ossification center. So what happens is blood vessels will bring osteoblast to a particular region in the bone that becomes the primary ossification center. That is to say, the primary center for bone formation, the first center for bone formation. Once you actually bring the osteoblast, remember, they're going to start laying down bony matrix. And so you're going to start to develop, then after the laydown of the bony matrix, you're going to start developing the medullary cavity. And then shortly after that will become the secondary ossification site. Now, spongy bone in the diaphysis, which is initially laid down first, is absorbed by the osteoclast in what's called a remodeling strategy. And then that's going to form what we now refer to in the mature bone as the medullary cavity. Now, shortly after birth, the secondary ossification centers form in the epiphysis, that is to say, the tips of the bone. So you form your diaphysis first, you clear out your medullary cavity, and then after birth, you develop your epiphysis and your secondary ossification site. So then, once you actually get your epiphysis, your epiphyseal growth plate, which is a band of cartilage that remains sandwiched between your primary ossification center and your secondary center, becomes your growing plate. This is your growth plate. So limbs will keep increasing in length as you get older, as long as you have that epiphyseal plate. And the part of that plate is you have to replace that hyaline cartilage, so you have an endless supply of cartilage to convert into bone. And you keep adding layer and layer and layer of bone to the length of your femur, which is what gives you your height. So you have two locations of cartilage right now. When you're between the ages of birth and 18, your growth plate is the one main area of cartilage, and also your articular cartilage, which you never lose. And this covers the ends of your long bones. So here's what it looks like. So here's basically our first step, our cartilaginous model. Then what happens is in the next step, you basically form, what's happening here is in the diaphysis, your cartilage calcifies. And that seems to be the trigger for bone deposition. That triggers the osteoblasts to come in and start loading bony matrix on this collar. Now, this region right here is calcified. This becomes calcified. And that gives you the trigger to bring in these osteoblasts. So blood vessels will invade this area and deliver osteoblasts. And once the osteoblasts are in there, they're just going to start laying down matrix. They're going to replace this cartilage with matrix, with bony matrix. And you can see the bone is advancing in this direction and in this direction, making this calcified cartilage region even smaller and smaller and smaller. Now, at the same time, when you get to secondary ossification center, the blood vessels will invade this region of cartilage. Why? Because in the epiphysis, what happens is the cartilage calcifies here. Next, signaling the osteoblasts to come in and to invade that area. And when they do, they start laying down bone and they start building spongy bone. So now you've got bony matrix advancing in this direction and in this direction. It's like a two-front war for the hyaline cartilage just smashed in between. And then eventually what will happen is the osteoclast will come in here and clear out this medullary cavity, giving you an open cavity. You'll have spongy bone in your epiphysis, which is highly vascular. And then you'll have spongy bone here at the tips where your bone is advancing. And now this becomes your growth plate or your epiphyseal plate. And what happens is you keep replacing the cartilage here so that as you add a new layer of bone and you get taller and taller and taller, you add a new layer of cartilage as well. And that's what's happening at your growth plate. So ultimately, the layer that is on the epiphyseal side of this growth plate, so this is basically your growth plate or your epiphyseal plate construction, has different zones to it. On the epiphyseal side, so here's your epiphysis over here. You have spongy bone over there. But then on that the epiphysis side is what's called the zone of resting. This is basically where you have cartilage cells at rest. Then what happens is now below it, as you start to move down, you run into what's called the proliferating zone. So this is basically where chondrocytes are producing new cartilage cells, essentially adding to the plate thickness. From here, then, you're going to get to the degenerating zone. This is where the cartilaginous cells will die off, and they'll leave behind their open lacuna. And then they'll calcify. And remember, that's the signal for the osteoblast to come in and replace. And the last one will be the ossification zone, where your osteoblasts replace the cartilage. With the bony matrix. So the idea is so once that layer gets replaced with bony matrix, and you add a new layer of bone to your growing long bone. But the thing is, the key is as long as the proliferating zone continues to produce new cartilage cells, then you will always have new cartilage to replace. This is what's happening when you're growing. This is what it looks like. So here you can see you basically have your resting zone up here. And then it's going to move into your proliferating zone. So you can see how you got many, many more cells. This is adding to the thickness of your growth plate. Then you have the degenerating zone where they die off. And your ossification zone where the osteoblasts will replace the cartilaginous matrix with bony matrix. And then what happens is you basically add a new layer of bone on top every single time you go. So you're basically growing in this direction. But the thing is, your proliferating zone adds new cartilage to the plate. And this is how you grow. So basically, as you continue to add new cells, you basically kind of do this treadmill effect where you basically add multiple layers of bone as you basically grow out. However, you can't grow forever because essentially your epiphyseal plate will close and then the bone will finish out and convert all of the cartilage to bone. And what it means by close, it means that the chondrocytes stop dividing. So you're no longer adding new cartilage to your plate. It's done. And so your osteoblast will then fill in the rest of the cartilage, and then you'll be your maximum height. It'll be all converted into bone. And that's what happens when we're 18, we stop growing. So a couple of hormones that play a very important role in bone growth, vitamin D. Why? Because it basically helps to absorb calcium. Growth hormones, testosterone, for instance, thyroid hormones, and of course, sex hormones, rather, for testosterone, for instance, and growth hormones, which will actually stimulate cell division. And this will happen in the hypertrophy zone. So vitamin D basically is formed in the skin, and it's important because essentially this will allow you to absorb calcium from your food, and calcium is stored in the bones. It's also what hardens bones. So if you have a calcium deficiency, you get what's called rickets, which allows your bones to be too flexible. So you don't have enough structure in your bones, and they start to bow and distort and things like that. Growth hormones, which essentially stimulates the bone growth, that is to say the hypertrophy, cell division and hypertrophy. If you have abnormal amounts of growth hormone, you'll have too little, then you can be too small, so you won't develop to a normal adult height. So that's too little growth hormone. Gigantism is if you have too much, you're growing too much. So acromegaly is typically when you have excess growth hormone in adults. So you get this sort of abnormally large bones, abnormally large hands and face, for instance. And of course, sex hormones, which increase, especially in males. Testosterone, for instance, is one that has a really, really significant effect on muscle and bone growth. Then we get to the remodeling, and then we'll take a quick look at bone repair, and that'll be the end of the chapter. So bone remodeling basically is something that osteoclasts do. So what they'll do is they'll break down bony matrix, and then osteoblasts will build it up. And so by this process, you can recycle about 18% of your bone each year. And now if you have an abnormality in this one, for instance, if you generate too much bone, like faster than normal, so you're building more than tearing down, you get what's called Paget's disease. And so this will create softer, weaker bones. It can cause a lot of pain, deformities, and fractures in your bone. Since your bone is the storage site for calcium, calcium homeostasis is important. So for instance, if your blood calcium levels rise, so if you take a look at calcium and your blood calcium levels rise, some of that excess is going to be deposited in the bone. So you have mechanisms that will cause you to package that calcium into your bones, and it'll bring that level back down. If your calcium blood levels drop, then your calcium is going to be removed from the bones and put back into your bloodstream to bring that back up. So you have two different types of mechanisms to sort of maintain your normal calcium homeostasis. And so as you kind of go between these two oscillating points, this is essentially your normal homeostatic range. So what are some of the mechanisms we see? Well, first of all, when your blood calcium levels drop, you stimulate parathyroid hormone. So this will stimulate osteoclasts to dissolve bone. That liberates calcium. And that calcium will basically go into your bloodstream, increasing your blood calcium levels. It'll also promote the absorption of calcium in your intestines when you eat it. And also it'll tell your kidneys not to lose any calcium. All of these have the effect of being this little trough response. So that's your parathyroid hormone. Vitamin D is necessary for the absorption of calcium. So for instance, in order to get absorption in the small intestines, you need vitamin D to do that. Calcitonin has the opposite effect of PTH. So calcitonin will actually be the peak response in calcium homeostasis. So when calcium is high, it'll stimulate the urinary system to dump calcium and get rid of it. Estrogen has the effect of increasing the number of osteoblasts. So you're laying down new matrix building. This is one of the reasons why a reduction of estrogen when women go into menopause causes osteoporosis, because you don't have as much stimulation of the osteoblastic activity as before. So let's take a look at bone repair. Let's imagine you break a bone, right? So there's a couple of steps that goes into breaking a bone. The first thing that happens when you break a bone is you've essentially broken it, but you've also lacerated a lot of vasculature. The first thing you want to do is you want to basically stop the bleeding, and you want to create some structure quickly and cheaply and early. The first step that you're going to run into is what's called hematoma. So basically you got blood all over the place. And so you're going to, within about 6 to 8 hours, you're going to form this gigantic blood clot, which helps to prevent blood loss or stabilize blood loss and provide structure, support for the tissues. Remember, this is a connective tissue, blood is, so you can provide a little bit of structure, like for instance, those lacerated blood vessels and things like that. The next step that you want to go into, step number 2, is going to be the cartilaginous callus. So what happens is immediately you send chondrocytes to lay down a more structurally sound type of a plug, and that's going to be fibrocartilage. So basically in this one, within 3 weeks, you're going to have a fibrocartilaginous callus, which is going to plug the break. It's going to do that with more structural integrity. So it's a little bit better than just blood. So that's the next step. So you have cartilage, but remember, where you have cartilage, you can convert to bone. We just learned about that in the endochondral ossification strategy. So the next step after that is going to be the bony callus. This is basically where, this is happening within 4 to 3 months. This is basically where your cartilaginous callus turns into bone. So basically, by a similar process, to how endochondral ossification worked, right? Including the calcification of cartilage, which then triggers the osteoblast to come in and replace the cartilage with bone. And then after that, you're going to get the final piece, which is remodeling, which is essentially smoothing out the bone. Right? That's basically what's happening. And all the osteoblasts will basically form new compact bone, and it'll basically restore final structure. And this could take months. So basically, when you get to different types of bone fractures, they can be classified as either complete, where basically the bone is broken clean through, incomplete, where it's basically not separated in 2 parts, It can be simple or compound. So it's simple, it doesn't protrude from the skin. Compound, it does break through the skin. Those are pretty gory types of breaks. It can be impacted, where the ends are wedged into each other. These are like compression fractures, oftentimes. Or it can be spiral, where the ends are kind of a ragged, twisting kind of a type of a break. But ultimately, there's a lot of different types. So like if you get into orthopedics, you'll learn more ways to classify bone breaks, but those are the major types of bone breaks that we have. And then finally, of course, we have the bones as a reservoir for marrow. We have yellow and red marrow. Yellow is basically fat. That's where you store your fat. And red marrow is basically the site of your red blood cell production. Okay, and so we learned about that in chapter 6. And that is the end of chapter 12.